actually is an advantage. This time when it's got more experience, because they actually got more experience in different area. So if you haven't found your area yet, don't worry, because each place that I work in actually gave me different experience and different insight on how the system work. So in the very beginning, I thought I would just share these pictures with everyone. I'm sure some of you will have seen it because everyone is very IT savvy, and it's actually, when I see it, actually I can relate it to it quite a lot. Certainly has become looking more like the senior nurse looking most of the time now, whether I like it or not. And the consultants, most of the consultants are very lucky that they don't look like that most of the time. But I do see them, they are quite different when they are expecting different level of expertise from a medical student, intern and medical officer versus a nurse as well. So they do have different temper. But all of them, the more the younger they get, the more nicer they actually become. Not the old school style that they keep yelling at and putting people down. That probably doesn't see much anymore in this part of medical hospital. But yes, senior nurses can look like that, especially after 3 night shift, and then put on day the next day, and so does the junior nurse can look like that when they find out that they actually got something they don't know. That sometimes they say, I know, and then now I actually find out no, they don't. so I think this one is a good summary of how different step and different phase of our experience come in, and then give us a different phase. Also in here, I would like to, since you guys will be first into hospital more full-time, the nursing staff can be quite overwhelmed because there's a lot of us and it's a lot of different roles. So I thought I'll take this opportunity just to go through in a little time to go through. There's actually different position to look after different area. To start with, you got assistant in nursing. Their qualification is about Cert 3 and Cert 4, which is a 12 weeks online training in with TAFE or qualified training. And mostly they will end up in aged care facility. We really need them in there. And also you will see more numbers of AIN in a more general ward, general medicine ward. Not so much in like surgical or palliative, you don't really see them. But they are great resource, great person to go to when you want to know what happens to the person, her skin integrity, her pain level, her movement. They are great because they are there for the personal touch part. Then we got the enroll nurse, which is, we call them EN, which needs a 2 years diploma qualification, and they are registered with APRA, so they are responsible for their own action. And then they can do a bit more than an AIN, but they have to be supervised under RN at all time. So most of them does not do medication, or unless they are specially got trained and have approved by that particular ward. So when they move to another ward, they might not be able to administer medication. And then you got the majority of RN. RN also include midwife and also mental health RN as well. They are quite different. We kind of find our own specialty and then we just kind of stay in that area. That means the RN require 3 years of Bachelor of Nursing and then 1 year of postgrad program. That means they need to rotate in a larger hospital that got graduation program, and usually is 4 rotation within that 12 months. So they have different experience on 4 different area in the first 12 months of their graduation. And then we also of course is under APRA as well. And then we see the clinical nurse. Clinicals, and go back to RN. Actually, RN got different different level. That's from RN 1 to RN 8 in New South Wales. and it's go up per year. It doesn't matter whether that person stay in the same position doing the same thing, but you can have RN1 work and RN4. It doesn't show in the badge. It doesn't show anywhere else. It's really just their registration. So, and that comes in a scenario that I actually want to share with you guys. That was the first day of me working. I was in UK working as an agency nurse, and that was my first day got assigned to that one particular hospital that I'd never been before. And I was sent to a surgical, a day surgery, very easy, just to recovery, do the ops, and then nothing too complicated expected. And then walk in, there was a patient needing some Panadol. And that was before the nurse initiate medication list that I could give Panadol without a prescribing in the med chart. And wait a few hours, and finally a doctor's arrived. So I certainly grab hold of her and want her to write down on the med chart so I can give the Panadol to the patient. And later that I know that it was also her first day in the hospital as an intern. So neither of us never seen a med chart in that hospital before. And we kind of just grumble each other so to make sure that all 5 rights are written there. And I check and double check and triple check. And just for two simple paracetamol. And kind of, she was asking me where to sign, and I was telling her where I could see that it's for signature to sign without actually someone showing me first. So, and either of us know each other, but yes, we got the problem solved, but it does happen in a busy hospital. So, and after during the 8 years of RN1 to RN8, in the middle, we can apply for other roles. We don't need to stay till RN8 before we can move on to the next senior role, as long as we pass the requirement. Sometimes it's a higher education during the 8 years, as well as by experience. So that brings us to the clinical specialist, CNS. Each ward or each area should have numbers of CNS on the ward that look during the clinical site for the RN, especially the RN1. So they are the ones who done more additional study, like including certificate, but also most of them will have at least a diploma or master degree for their chosen area. And they should need to be quite experienced in that particular field. That call to have that to get that position being a CNS. And the next level up is the CNC, which is a clinical nurse consultant. They do what the CNS do in plus more management part. So they are one level up. So there's not many of CNC position left because they usually is CNS overlooking RN. And then we have the next level is the nurse practitioner. I'm sure when Lucy first introduced me as nurse practitioner, most of you probably think, what did she just say? Because it is very normal, very common reaction, because there's really not that many of us. There's about 2,200 for the whole Australia. Or different field that we chose ourselves. Myself, I chose to be the palliative nurse, and how I able to become one is actually need to do a master degree specifically for nurse practitioner. And we graduate as a general, we need to pass the Viva, and I'm sure all of you know how scary Viva is. And it could be so not controllable that it could be either way for any direction. And I was very lucky I was able to pass it the first time. And also means that I need to be, in order to get this position of palliative nurse practitioner, is that I need to be having at least 5,000 hours in senior palliative role within the last 6 years. So before this position, that I'm eligible for this position to apply. And of course, the difference is what the next level is that we actually register with Medicare. we do have a provider number and we do have a prescribing number. So we can, so our clinical role include the prescribing part of it. And it's very handy in aged care area. It's very, very needed. But also in palliative care, I found it's a lot of end-of-life medications that I do prescribe almost on a daily basis, mainly because one is more another prescriber, an extra prescriber in the team, and also the medical and me work really, really hand in hand together. So that is the clinical side of nurse position. It is very daunting, but also I can remember in the hospital setting, in busy hospital setting, especially the first few weeks, everyone got their own names on it, name badge got their position in it. But actually, if you ask the questions to RN1 versus RN8, you probably get quite a different answer. Also, certain information, if you ask an EN versus a CNS, you also get quite a different answer. So, and you can see I purposely put it all in level, all 6 position level, because I can't work without any of them. Although, yes, nurse practitioner got the most qualification, but I actually cannot provide the care that I want with my care plan without any of them missing. So every one of them are equally important to me. And then for the management side, if you have concern on any nurse's skill or nurse's approach, those are the people you can go to. We have the nurse unit manager. Usually it's the one with the worst hairstyle because we're just so stressed. So all the time. And also the clinical nurse educator is the one who's responsible for the education for almost the whole floor rather than just one ward. And also we have the director of nursing, which is one for the whole hospital. Need to be a RN registrar and also a DDON, deputy director of nursing. So they are the people you can go to if you have concern on particular nursing skill that you want to improve that group of nurses that you work with. Those are the people to go to, and they will be more than happy to, when you identify something, and they will be able to provide and put it in the plan. And I think this is how modern nursing is more working now. Medical and nursing are very much working together rather than separately. One is nurses got a voice, as well as medical. They are a lot more respectful and more understanding what nursing and medical role are hand in hand, which is great to see. And I put that pictures there. And I think one thing is, the hospital do think we waste a lot of money for each dressing that we recommend. That is like putting water in the in the toilet. And then I would like to also have this up there because, like, go back to the first pictures, the senior nurse sometimes do look like that cat, mainly because we got multiple things need to sort out all at the same time. And then you got one patient's safety always come first, and then you've got multiple patients all climbing out the bed. And yes, we do give the patients this kind of look. But in the same times, because we can look scary, but also because we care, and because we got multiple things to get fixed within the 8-hour shift and want them to be done, because we're very cautious to pass it on to the next group, next shift. But what we love is you guys ask questions, keep asking questions, keep telling us what you're thinking and how, because by the time the first week we know your first name, you can't run anywhere, because we will be grabbing you, and Lucy will know that get another can you write another IV out, get another mat chart, and then you guys will, where's the key? So you guys will be part of the family very, very quickly. So please don't be off because we have that kind of look on our face at times, because there is a reason, and it's not because of don't take it personally. And because we really do need to work together. And one last thing I'd like to, with this slide, is about to share is too often we underestimate the power of a touch, a smile, a kind word, a listening ease, an honest accomplishment, or the smallest act of caring, all of which have the potential to turn a life around. I found this phase very, very close to heart. One, because yes, it's palliative care, but also we are dealing with another human. No matter how science and research driven, we are facing another human. And a lot of time it's not just one human, it's humans and the family who loves them all together to have that one big accidents, traumas, or concern. So never underestimate how your approach, how your energy, and how your tone of words will mean and how they remember it. Because at the end, they might not understand a lot of medical terms. They might not understand what's actually going on, but they do remember that someone's actually takes time and explain to them or trying to explain to them. There was one, allow me to share one particular shift that I actually in a palliative care setting, and difficult questions and difficult conversation is more or less is a regular scenario. A lot of them about death and dying, a lot of them about giving up, a lot of them about saying goodbye. But there was one particular shift. There was 3 patients all in the same time, in the same day. They decide on that day that they want to have a chat with me about not for further treatment. That they had took all their times, they have lots of time with family to talk about it. And that was the day that they all decided to have that conversation with me. And I remember I tried every patient's, every start of conversation, I use the same tone and really same patience. But at the end of the day, I remember at the end of that shift, although I was 2 hours behind, but also by the end of that shift, I went to the nurse's station. I just collapsed on the chair. I could not speak for 15 minutes. It was just so heavily on my heart. I was very glad that I've done it. I was very privileged the patients actually chose to express themselves on that day. But in the same times, it makes me feel, but also it's a shift that I feel most, one of the most satisfying shifts I had. And I remember I couldn't talk for the whole 15 minutes. Even the consultant who doesn't really take much notice of me, that he actually asked me how I am. And I went home and I think I cried for a whole hour. So it does happen. We are human. So does the patients and the family. And I would like to finish with this slide to not just for you and not just the relationship between you and your patients and the family that you will come across, but also to each other, to your colleagues, to another person who start the intern with you. They're all going through the same struggle. And there's no shame to share how that feels, how that make you, because that actually make me a better person after that shift. And to look after each other, because you guys is just the beginning. Don't burn out. Thank you.
Thank you, Carmen. That's such a good reminder at the end, and reminds us of what we do, why we do what we do, and also very informative of all the charts. And really, honestly, I'm learning as well all the different kind of people and the requirements to get to each stage. So thank you. Opening up to the room, does anyone have any questions? You can unmute yourself or you can type in the chat box. I'm going to allow about 10 seconds of awkward silence while we wait for people to ask any questions. And if not, we will move on to our next speaker, Jeff. But I'm just going to hang in there and wait a little bit just in case anyone has any questions. This part of Zoom is my least favorite. All right, going once, twice, 3 times. All right, if you think of any questions, you can always type in the chat box and we can answer them later. So next up we have Jeff, who is our lovely pharmacist who will be giving his talk.
Thanks, Lucy. I'll just end. Thanks, Carmen, for that introduction as well. Great presentation. I'll just share my screen. Can you see that?
Yep, can see that.
All right, great. Okay, all right. Hi everyone, I'm Jeff. I'm one of the pharmacists currently working at Ryde Hospital. I've also worked at North Shore Hospital as well. I've been a hospital pharmacist in the last few years. This is a very new area for me that I'm entering in. I've also done a diabetes educator course, and I'm currently doing a master's research degree as well in opioids deprescribing at Transitions of Care. And so I was invited by Lucy and by the organization to do a presentation today as well. So thank you so much for the opportunity. I think it's always good to help interns such as you guys joining the workforce, joining the healthcare system and understanding what are the do's and don'ts as well. I'm sure everyone on the panel today could understand where I'm coming from as well. I guess like a 20-minute presentation is never enough on explaining what you can and cannot do. You learn as you go with these things. And then it's only through experience that you learn from mistakes as well. You know, like we fail to learn. That's basically it. And so some of you guys may have done placements already as well throughout different hospitals. If any of you guys are joining Ryde Hospital in the next 12 months, feel free to come and say hi to me. I'll be there as well. Happy to help out if any questions as well. And so I wanted to focus on, I guess, some of the typical things I see on a day-to-day basis, even now with certain doctors who have been practicing for the last 2 to 3 years, and the mistakes that I see as well. So I wanted to share them with you, be aware of them, and let's have a chat about it too. I hope some of you guys are more open. Feel free to chat in the type in the chat box for the next slide. So these are some of the don'ts that I've listed here. So have a read through them. I'll go through each one as well. So this is a very typical sort of thing that I would see on a day-to-day basis as a hospital pharmacist. So for example, attaching patient stickers to SA scripts is illegal. Leave the discharging mess list on the ward and hope for the best. Because I did this at hospital A, I can do the same at hospital B. Tell patients the exact time when they'll get discharged. Don't just ask about oral tablets / capsules. And when you get a phone call over the phone, you say you'll get it done. Hopefully you're memorizing every detail, but you end up forgetting. So I kind of want to take the next 1 minute as a pause, and I want you guys just to have a look through the list and, you know, feel free to type and in the box and tell me what you guys think. Oh, go back, sorry. Feel free to type in the box and let me know what your thoughts are and what you would do instead as well. So I'll give you guys about a minute.
While they're typing, I definitely have done number 1 until I realized it was illegal. Well, like, I never got away with it. I have done maybe number 2, but I think I most of the time I do the right thing, which someone can type in the chat box what you need to do. And definitely number 4 is it's so hard because patients will definitely ask exactly what time they will get discharged, and we have to do the vague thing of like, oh yeah, maybe around time.
Yeah, and I think it's I think it's a very unfair task placed on doctors as well when patients ask when they'll go home, because they won't just ask you guys, they will ask the physio, they'll ask the nurse, they'll ask the pharmacist as well. So I think there's a strategy I always tell my doctors, like what you do to sort of, to like, I guess, not make patients sleep disappointed as well.
We blame it on the pharmacist. We say, ready.
Oh, it's always
it's up to pharmacy to get your beds ready.
It's always so funny because I think the patients, they'll be like, oh, okay, I'll just wait. And they get all really impatient. And at the end, they're just so happy. They just forget about all the disappointment that they had for the last 6 hours as well. And so, you know, there's I think there's a lot of don'ts as well, but I think there's a lot of things we can discuss as well. And I would love it if anyone would like to just unmute themselves or type in the chat box just to ask questions. You know, like, feel free to ask anything and everything if you want to. This is the time to learn. This is the time to know what to do. You know, you don't want to start at Westmead Hospital on day one, like or at like Royal North Shore or some other big hospital on day one, and then you realize, oh crap, what did Jeff say? What did Jeff say to do? Who can I call? I don't know anyone here, you know. Oh, we've got someone. So George said we should handwrite the essay script. Fantastic. Yes, great job. Good. Now, anyone else want to have a go at the other ones there? You know, like, you know, there's no right or wrong answer. You just got to just type in what you would do instead. You know, how would you avoid doing something like that? What would be a better approach to what I've listed there? Have a think about it.
Yeah, like, what can you do instead to keep all the pharmacists happy?
Yeah, exactly. You know. Thank you, George. Great job.
Well, you'll be a great intern.
Exactly. And George, can you just please elaborate? How would you hand over? What means of communication would you hand over? Okay, yeah. And with that, how would you communicate that handover? Where would you leave that ISBAR? Would you leave it somewhere? Would you type it somewhere? Like, how would it get to the pharmacist? How would you make sure it gets to the pharmacist? Great, exactly. In person, if possible, or over. Exactly, that's exactly it. And you give the ISBAR over the phone. That's exactly how you do it. I think in uni, we all tend to just, you know, we're all based on what we're taught and all the theory and like what is the like the proper things to do. And yes, I fully support like the best possible practice as well. But we need to be practical in the work setting as well. How are we going to hand over to the next allied health or the next doctor and things like that as well? So I think we've given enough time for you guys to have a look at those scenarios there. So let's have a look at what I would recommend you guys do. And if you have something better, please share it. So thank you, George. You would handwrite your essay scripts. And then you can ask the ward staff what the usual process is as well. Like, you know, you can also call the pharmacist and give them a handover over the phone. And so because I did this at hospital A, I can do the same at hospital A. Always check with your pharmacist, what is the process of the hospital you are working at? Every hospital has their own system. So just because you did one thing for an infusion at one hospital, that doesn't mean the same thing will go through at the other hospital. You have to always ask what the process is, because what will end up happening is you do it in the morning, you get a call by the pharmacist at midday saying that you've done something wrong and you won't be able to sort it out until the afternoon. And then all of a sudden it has to be delayed till tomorrow. So if you're not sure, just call the pharmacist. The pharmacists generally respond to their pages as well. It's just a very simple question as well. And sometimes it won't even be the pharmacist telling you what could have been done, but it'll be the nurses saying, no, doctor, this is the wrong approach. We should do this because this is what we do here, things like that as well. Telling patients the exact time when they will get discharged. So I always tell my doctors, under promise and over deliver. Don't give them an exact time. Don't say, oh, Mrs. Smith, you're going to be discharged probably, it's 10 a.m. in the morning. And then you say, oh, you're just picture yourself in the scenario where it's 10 a.m. in the morning, you're still in your board round with your registrar and your consultant. You see Mrs. Smith at 10 a.m. going home today. And then Mrs. Smith asks you, oh, what time am I going? And then you say, oh, you'll probably go home about, I'd say like maybe 1 p.m. today. And you know for sure you don't finish your ward round until 1 p.m. And you're going to do all these jobs, all this paperwork at 1 p.m. I don't think so. Under promise to the patient and over deliver. That's what I always tell my doctors. Under promise, tell them you maybe late afternoon, things like that, just to give them an expectation as well. Because if you tell them a time, they will stick with that time and they will hassle the poor nurses constantly saying, where's my meds? Where's my meds? And the poor nurses will have to blame on us as pharmacists saying, pharmacy hasn't done them yet, pharmacy hasn't done them yet. So always under promise and over deliver, because that's the best scenario to ensure that patients don't leave disappointed in most situations. Don't just ask about oral tablets and capsules. I find, I think patients tend to always only think about medications as what they swallow, but they never tend to think about what else they use. Eye drops, inhalers, injections, patches, creams, vitamins, and herbal supplements. I think you just open the question to them and just ask them, what other medications do you use that you don't swallow? Things like that, just ask, and then you'll be surprised at what they take. You'll be very, very surprised as well. And so too many things I see come through often that are always missed from the patient's history. That is like life critical as well. Saying you'll get something done over the phone, but hopefully you'll memorize every detail, but you end up forgetting. I mean, look, there's only so much information you can memorize from a phone call. So if you can't get every detail right, just set clear expectations with your pharmacist on how you want to communicate. Do you want to be paged? Do you want to be texted or called? Or do you want us to leave a note? I think set very clear expectations with your coworkers on how you want to communicate. And this doesn't just go with pharmacists as well. I think what you'll find actually throughout any career, and I think the panel could understand where I'm coming from as well, setting clear expectations with your registrar, who will be your leader, and your consultant or your resident as well. I think setting clear expectations with them, or they set clear expectations with you on how they want to be communicated, is really, really key on having a successful rotation, I think, as well. Being organized. I'm sure Lucy could probably expand more upon that as well, but I think communication is extremely important, and making sure how you want to be communicated is really important as well, because sometimes the poor pharmacist is just calling you to sort something out, and if you're having a bad day or they're having a bad day, it's just really important just to be very open about these things as well. I think I echo the words that Carmen was mentioning earlier as well. I think in this day and age, we know we're dealing with COVID patients, and it's everyone's burnt out. Right now, everyone is very burnt out because currently no one is allowed into hospitals. So it's very challenging for patients' family to understand what is going on, the progress as well. So I think the expectations on how patients' families see how their loved ones are progressing is very different to how you see it as well. So, expectations is a key thing in the workplace setting as well. So, look, I could talk all day about what you shouldn't do from a pharmacy perspective as well, but go on about this all day. There was just keeping track of the time. There was I read about an incident the other day where I think a patient received a clindamycin script. It was a 10-year-old patient received a clindamycin script, and it was 390 milligrams 3 times a day. Now, clindamycin doesn't unfortunately come as an oral suspension anymore, and it only comes as 150 milligram capsules, and you can't really dissolve that very easily. So, I think checking with your pharmacist, does this dose exist? Can the parents give a dose like that? I think if you're not sure, just ask. There's no harm in asking. Like what Carmen said earlier, just ask. There is no harm. We rather you ask than not ask at all, because at the end of the day, the one who gets the least benefit and gets the most harm is the patient, and that's not good enough for all of us as well. And so this is just a very basic list of the don'ts list. Is there anything you'd like to add, Lucy, or anyone would like to, type in the chat box? is the time to ask now.
Yes, please ask questions. No, definitely, Jeff, everything you said. And I really think it was really good kind of towards the end of my internship, beginning of residency, where I've worked on a few wards, I've gotten to know a few pharmacists, and I think I like having people's numbers, and I like people having my number, especially with a lot of things like medications and doses. Sometimes you don't remember, or you're like, oh, I'm just going to double check, and you want to get back to someone. And honestly, I personally really don't like the paging system. I think it's very outdated. I think sometimes it's just really easy to text people, oh yeah, by the way, I checked with the patient, they're actually taking this dose at home, I'm going to change it, just things like that. I think it's really helpful. And it's also kind of just like, once you know someone, it's easy to ask them things and double check. And sometimes I might ask a pharmacist who's not necessarily covering my particular patient, but I just find them a really good resource just for general medication questions. But like a lot of the times, guys, pharmacists know so much about medications. Like your reg or your consultant probably don't even know the detailed things about medications that you can ask pharmacists. And I think they have secret ways of checking things as well that we don't know about.
We have access to resources where no one does. No, I'm just kidding. No, we get access to the same resources. That's basically it, guys. Just just ask a pharmacist. I think go, when you break the ice when you get used to the ward, or you break the ice with your pharmacist, I don't know, go for a coffee with them or something. This is like the workplace setting. You go for a coffee with them. If you don't like your registrar, go for a coffee with the pharmacist, because that's what we do at RIDE. I have coffees with some of the doctors day to day as well. So just get to know them, because you're now joining the healthcare workforce as well. I think it's really important that you try and maintain good relations with different allied health, and not just allied health, but also with your seniors as well. These people will take you to places eventually in your career. I just don't make anyone get angry, or don't do anything to upset someone, because especially in your own industry as well, because this is the beginning of your career, and you want to set a very good foundation as well for it. Anyone else want to ask any questions? If you're joining me at RIDE, come and say hi. So anyone going to RIDE Hospital? Anyone? Just type in the chat. Or you can privately text Lucy, that's fine.
If Jeff seems too scary, you can tell me.
Oh.
All right, maybe no one going to RIDE, or everyone's too shy.
Oh, probably. Okay. Oh, well, and I think, all the best, everyone. I think reach out to Lucy if you have any questions for me as well. But, thank you so much for attending today. All the best with your careers.
Thank you, Jeff. Thank you for the talk. Definitely very common mistakes to be made by many interns. All right. If no one has any questions, I will pass the mic to Rosanna to give us a chat from the physio perspective. Rosanna, you're muted at the moment. There you go.
Got it. Hi, everybody. Can you hear me? Yes?
Yeah.
Okay, I just share my screen first. Okay, then, okay, I need to get that way. So, slideshow. Okay, then proper beginning. Good. Okay, good. Yeah. Okay. Hi, good morning, everybody. It's my pleasure to be able to share the do and don'ts, in the physiotherapy points of view this morning. And thanks for AMSC to give me the opportunity to share the info to you. So I'm Rosanna Ng. I'm a physiotherapist, Actually, I'm a musculoskeletal physio as well as a pelvic floor physio. Been working 40 years plus, and also I'm in private practice now in the past 34 years. To get this talk, actually, I did ask some of my physio friends that work in a hospital. So give you more about, the whole picture about do and don'ts. I try to, okay? Sprained ankle is the first talk I talk about, which is very, very common, okay? And then when the sprained ankle patient come in the emergency, so do have a good assessment. Don't just send them to X-ray. Use the Ottawa, okay, the ankle rules, then it will cut down about 30% of the unnecessary X-ray. And with the assessment, of course, you do the good palpation and where's the soreness and that sort of things. Then you know whether it will be a fracture or not. And then if they can walk 4 steps, with, of course, maybe with a limb, they'll be scared. But if they can walk, they limit the chance of fracture already. And then if it is not necessary to give them a moon boot, don't give them a moon boot because it will, it's a waste of money. And then the other thing is, if they don't know how to use it, then it will stiffen the problem. I had one patient that come in with a moon boot with a pair of crutches. Actually, he doesn't know how to use the crutches as well as he doesn't know how to use the moon boot, and that creates the plantar fascia pain, and then we have to treat it. So good assessment is very, very important. And then deciding on whether they are walking properly or they are not able to walk. If they limping, then they're not able to weight bear fully on the leg. So I think maybe a stick is enough, or they have to use crutches. So sometimes I just give them a stick and see how they use it. If the stick is no good, then you think, okay, crutches, they need a bit more assistant crutches. Then we have elbow crutches as well as the auxiliary crutches. So you have to decide on which is better for them. For a little bit elderly or a weak person, the underarm crutches is probably a bit appropriate because it is more stable. A forearm crutches, it is for younger people. So, but forearm crutches is safer because they won't weight bear on the axilla and causing nerve damage. So, if you decided on, they have to use forearm crutches because they're unstable, they're not strong enough to use the elbow crutches. So you really have to warn them, okay? Don't weight bear on the axilla. Okay, because tell them why, because a lot of nerve blood vessel there, and hopefully when they saw the weight bear on, they saw they won't, but if not, they actually will cause paralyze, cause nerve palsy. So then we teach them how to use the crutches, how to walk. So it's really important you decide on whether it's a non-weight bearing touchdown or it's a partial weight bear. And you tell the patient why, what to do, whether to weight bear or not to weight bear. And the purpose of using those crutches or stick is trying to get them to walk as normal as properly. So even if they use crutches, and if they can be partial weight bear, I tend to ask them to walk normal gait, heel down, toes off, that sort of thing. They can't just put 20% of weight or 30% of weight or 50% of weight on the leg, depend on the bone. So, but do let them know, whether they're supposed to put weight or they're not supposed to put weight. And also, it is good to teach them how to get up and down stairs Or sometimes patients say, I don't have to add stairs at home, but I always say, you may have a curb, you may have to get down one step. At least it is the rules that they have to learn to do. So I always say going up, good leg up, and down, and going down, bad leg down. Okay. Then sometimes I'll just tell them that good, heaven is good. Okay. So that remind them to use the good leg first. So, and then to walk down, okay, it's bad, hell is bad, so you go down with the bad leg. The crutches is always with the bad leg. So you can have the crutches, bad leg, and then good leg. So, and try to send them, although they're quite happy, they know how to walk and that sort of thing, do consider we will for the patients, send them to outpatient or physio, because they have to be reviewed, okay? And when they get better, okay, their muscles need to be strengthened. Okay, the proprioception sense of the joint need to be educated so they can prevent the chronic ankle injury or chronic ankle and wrist sprain. So that is simple ankle injury. Okay, I'll get into the next slide. This one, it doesn't work. I don't know why. Okay, it's stuck. Okay, it worked now. I'll probably stay in that slide for too long. That's why. For hospital, intern, okay, mobility assessment and treatments. You always thinking, refer every patient for a mobility assessment. Don't. Okay, if the patient is already moving around, don't have to write that mobility assessment. And also, okay, if the patient is and they have to pass a weight bear on one leg and non-weight bear on the other, don't refer either, because it's just so hard for physio to do this. It's impossible to pass a weight bear on one leg and non-weight bear on the other. Okay, so they have to wait until at least both legs, this one leg has to work a bit better. And also try to involve physio a bit earlier for discharge. Quite often in hospital, we get the referral and telling us, the patient is going to discharge, this afternoon or tomorrow, teach them how to walk and that sort of thing. It is, a lot of stress at that time, and all depends on whether the patient is able to take all those information, are they strong enough and that sort of thing. So if they involve the physio to get the training and get the strengthening going, it's just easier. Okay, work. The other things that you will do in emergency is pastoring. Okay, I'd like to share some of this skill with you. Okay, pastoring, okay, is stabilize the joints below or above, okay, and for the lower limbs, try to get the ankle, okay, at neutral or 90 degree or panagrade. So when they weight bear on the heel, they can. The other thing is for the hand pastor. The pastor not supposed to exceed the distal crease of the hand, so the MCP joint able to move. If the pastor is too high and then the joint is not able to move, the hand become non-function. So, and it will cause a lot of stiffness afterwards. So when you do the pastoring, just watch this. That's two things. It's quite important. Don't use hot water or warm water. It will set the pasta quicker unless you got really confident skill in in a shop, in making the pasta. When the pasta is made, you're looking at the things nice, okay, but then actually it's starting to instruct the patient about the care. So about, if it's too tight, will get numbness and that sort of things. And then if they have numbness or increase in pain, ask them to come back, to maybe replastering and that sort of things. Okay, always warn them about this. And the other thing is, getting the patient to move the joint that is not involved. So if it is the wrist, that's fractured in plaster, fingers can be moved, the elbow can be moved, and the shoulder can be moved to prevent frozen shoulder or stiffness at the end. Because patient, if you don't tell them, patient really, they don't know and they worry and they will be stiffened up and it will cause a lot of pain and stiffness. So the other thing is, especially for, if they need plaster, of course, they have fractured. So their part need to be elevated as much as possible to decrease the swelling. Otherwise, if it swell up, the circulation will decrease. It will just, not as good. So I always ask them to elevate the part. And after a week or two, okay, actually the plaster should feel loose because the swelling decrease. And if they find that they can move too much in the plaster, ask them to come back. They may need replastering. So you can send them to actually physio, okay, to check and then replastering then. And tell them not to put anything inside the plaster, not to scratch it, okay. And so if they don't like the heavy plaster Paris, then they can go to the physio, have the synthetic plaster, and and then also there is a waterproof under layer, so that can be done. Okay, the next is rehabilitation that we physio always do. For the musculoskeletal problem, okay, it's just that surgeries like total hip replacement and back surgery. A lot of time, patient after the surgery, they can walk quite, they can walk. And a lot of doctor will think, they can walk, okay, they don't need physio. So do send them to physio because the muscle has to be weak, okay? Certain muscle will be weak. And then it's good to strengthen those weak muscles to balance the body back. And the other thing is, are they walking properly? Have they changed the gait? And then if they're limping, okay, and they will cause other problems as well. So it is just good to send them to physio, okay, after the musculoskeletal surgery. So we can follow up and make sure the joint is not stiff, the muscle is strengthening, and they're walking properly. And like the total hip replacement, if it's a posterior approach, there's a chance of dislocation. So we can warn the patient and educate the patient, tell them a bit more, because you may already told them, or doctor has already told them, but they can forget. The other things about the back surgery is, okay, then we can teach them, okay, how to do the core exercise, strengthening the core, and teach them the right posture to sit or stand, so to prevent further things that are happening to the back. Good. Okay, the next things, okay, about do is to send patients to physio or pelvic floor physio if they have stress incontinence. So if they cough, sneeze, lift, okay, or have a jump, and they have, I feel leak, although maybe a drop or two, okay, then it already shows us that they have weak pelvic floor. And it is better for them to train immediately as soon as possible to prevent further weakness or, okay, prevent it get worse. So do send the patients. You can actually teach them pelvic floor exercise and review them after a month or a few weeks, okay, and see whether they're better. But research told us that 40% of those patients, although they were taught, they did it, they do it not correctly, incorrectly. So, and if it is not better, do refer them on to public for physio to have them trained properly. And the other things about, is frequency of urination. It happened to men and a woman. So, and besides, the medication may help, but then they do need bladder training, especially the younger patients. Don't think that it always happen to older people, but I treat a 18 years old girl, and the mom found that she go to dinner before sit down, she go to the toilet after dinner, she go to the toilet, and the mom think, there's a problem, and send the girls to me, and and it just need a bladder training, talk education, and fix up the problem. So, and they are better to be, treated as early as possible. Pain management, So, we educate patients to cope with pain is very important. So, not, medication is very important to relieve the pain. But then, if it is a chronic pain, they may be over-drugged, they're taking too much medication. So we try to get them to focus on function, and trying to focus on ADL and not just pain. And we try to get them to manage the pain. If they have pain, maybe a hot pack can help, and maybe a little massage, self-massage, a cold pack, that sort of things. So pain education is very important, and do think about it, and we physio can help, in that sense. This is my last slide, and it is really important to work as part of the multidisciplinary team, and then the same goal is to get the patient better. So, and connect with everybody, and getting the things going. That is really important. So, any questions?
You can type in the chat, guys.
Yeah, I got 5. There's a 5 there. Ish. No, so I just stop sharing.
Thank you, Rosanna. That was very helpful. Very practical tips.
Yes, very practical. Physio are practical person.
Definitely. I learned a lot. I'm on ED, and just yesterday I had a patient come in because their plaster was on too tight on their foot, and it was their little pinky toe was getting numb, and I used the plaster cutter to cut off just the edge to give him his circulation back. And definitely the thing you said about discharge planning, that is definitely very much, I think every team is guilty of the physio to clear for discharge on the last day of the hospital stay. It happens too much than it should.
Yes. So there's a lot of little things, and then it just work together to to make the discharge, make the patient more comfortable. They know what to do and that sort of things.
Yeah, definitely. I think physios are also great educators of the patient, and definitely I think reading physio notes, I always learn things, or sometimes I have to look up all the abbreviations of the different like the weight bearing status and mobility. I didn't know what FASF was for the longest time, forearm support frames. It took me a while. The forearm support frames, and I don't know, the physios at my hospital always abbreviate a lot of things. So look up so many things and learn all the abbreviations.
Yeah. Different hospital, different people have different abbreviation. But then I think there's a list of abbreviation in a hospital that you can look at.
Yeah.
And,
Definitely. All right, if no questions, guys, I will do my presentation, but if you change your mind, you can also type in the chat. Thank you again, Rosanna.
My pleasure.
All righty, so I'm gonna share my screen. Can you guys see this PowerPoint? Yay?
I have to remove spotlight. Yeah.
I will spotlight myself.
Yes.
All righty, great. So I'm Lucy. I am at the end of my resident year. So I've been doing this for 2 years now, and everything that I say, I feel like is kind of like a guidepost, and definitely it's all the things I say are kind of things that I couldn't do at the beginning. So if you feel like you're struggling to do these things, I think it's completely normal. And to be honest, I feel like when I asked around my peers, it's like, when do you feel like you kind of got the hang of kind of how to do your job? I think that feeling tends to come at somewhere between term 5 of internship and kind of term 1 or 2 of residency. You kind of get a sense of like, all right, okay, I kind of get it. I know what my job consists of, and I can kind of get into the flow of things. So in the beginning, I think it's important to keep in mind that it's a struggle for everyone, and that's completely normal. But these are just some of the things that I felt like, what was told to me by my seniors, or I kind of figured out along the way, that I thought was just some helpful things to aspire to. So the first do is make the most of your orientation. So I'm not exactly sure how orientations are run these days in the age of COVID, but when I did it, it was 1 week of kind of the admin side of orientation. We went like lectures, and there was a lot of the compliance kind of things. And then the second week was a clinical buddy week, where you get to tag along and shadow like an internal resident on the actual team you're going to be working at. And I do know that sometimes, I think last year they've integrated a lot of Zoom into this kind of this area of the first week. So if you do get the chance, try and get to know your fellow interns, residents, allied health, and your JMSU, so your staff unit during this O week. Sometimes, because you're going to be split off into different terms. There were many interns I met during orientation and then kind of just didn't see again for a long time. So these 2 weeks actually are really good to get to know your fellow colleagues, get their names, get the number, make sure you're a part of the WhatsApp group if you have one, or if you don't, you can be the one to make one, be part of your Facebook group, and just to be kept in the loop of, what's going on. And oftentimes there will be like a residents association at your hospital. I do know that some hospitals, resident associations are more active than other hospitals. If your hospital isn't particularly active, you can be that person to get things going, because I think it's really nice to have a bit of like a social, social environment. The second thing is what? So during O week and the buddy week especially, try and learn as much as possible and get a handover of the specifics of this particular term you're going to go into. So I think a lot of what I'm going to talk about is kind of your typical ward-based term, whether it's medical or surgical term. But there are a lot of other things, like you can start off in ED, some people might start off in relief and be doing after hours. So kind of with these special and different terms, it's again really important to get an idea of how the workflow is, what when does work start, how do you know which jobs to do and how to prioritize. So chat to the person doing your current job. You can even start chatting to them in the more admin week, just to get a sense of what you're expected to do. The next is when, so know when your work hours are and how to claim overtime. So definitely, I think we will all be working rostered overtime and realistically a lot of unrostered overtime as well, especially in the very beginning as you're learning the ropes. Sometimes it's very normal to be a bit slower than you want to be, But when you're working overtime, you should 100% claim your overtime. At the beginning, I would always feel like, oh no, it's because I'm slow. So therefore, my overtime is just my own fault. I'm not going to claim it. But I don't think that's the right attitude to have, because you're there to learn and everyone is learning and everyone's slow when they're learning. So you should claim your overtime. A lot of the hospitals these days have an online overtime claiming platform. So it's on your staff link. And I think they'll go over this in orientation, but it's like kind of like they call it UROC. I'm not sure why. But then you kind of create lines of when you worked overtime. So make sure you keep a documentation of that. Remember the last patient you saw or wrote a note on, and make sure you claim that overtime. These days, I don't know if you guys have heard, but I think there's like some class actions against hospitals not paying overtime. So I think hospitals in general are a bit more aware of the fact that they can be sued if they don't pay overtime. And so they're a little bit better than the days past about paying them. And then also a thing is do a walk around the hospital, especially know where pathology and radiology is and where all the different wards are, because you might need to run samples to pathology or take your patients to radiology or take a disc to radiology to ask them to upload it. So knowing where they are is very helpful. And then how, I guess, to do your job. One thing I would say, advice is during your buddy week. I mean, some of you might have already worked as an AIM in your final year of med school because of this whole COVID thing. But if you haven't, or even if you have, in the buddy week, I think, maybe the first day you can say, oh, I'll take a back seat and watch how your intern does their job. But definitely from the second day onwards, you should ask to be the intern. So you should hold the pager, do the ward round notes, do all the jobs, because kind of the thing is, after that first week of buddy week, that's it. After that, it's just you're the intern now. So definitely, in that buddy week, you shouldn't kind of take the back seat and just watch, because then you don't realize what's hard and what you don't know until you're the one doing it. So be the one who does it, but then you'll always have someone there kind of to tell you what you should be doing. So next, so don't be afraid to ask questions. So including admin questions, so your work and contract. So those questions are questions for the JMSU, the junior staff unit. You usually have a manager and who kind of deals with the allocations, rostering and things like that. And you'll have a DPET who is the education, the person responsible for like junior doctor education. And they're usually a medical doctor. And like our one, he's an ED consultant. I know some hospitals have like a general practitioner or a non-GP specialist as their DPET. So they're the person you go to for your education and training. And then you typically have some people who are on rostering, payroll, and kind of admin support. So get to know them, get on their good side. I'm not saying that they're going to give you a bad roster if they don't like you. But if you kind of know them, and it's sometimes easier when you're trying to swap a shift or ask them, to kind of, give you an ADO in this particular special day. So I'd say get on their good side, and, kind of help them put your face to your name so they remember who you are. And clinical questions, like Jeff briefly mentioned, set expectations, know what is expected of you. And when you should, just double check with your reg. Oh, hey, by the way, do you want me to tell you and run it past you whenever, I review a patient, whenever I get asked to make a medication change, just what do they want you to ask them? And there's also kind of specialty specific things that really you don't learn much in med school. Like, I still don't know that much about hematology patients, for example. So at the beginning of your term, I think it's good to ask your reg or even your consultant, like what are the things I should be learning this term and what should I read up on? So you have a general background knowledge and refresh some of that clinical knowledge. In terms of workflow, again, this is kind of more on like a ward-based, team-based term. So I find it really important, like this is a very specific example, but when you're ward rounding in the morning, I think as an intern, sometimes you're just typing down everything that the consultant and the reg says, and you're hoping you get everything down. But I think it's really important to actually be assertive to ask questions, because often, I don't know, registrars, they would examine someone and they'd listen to the chest and they'd hear, a clear sounding chest, but they wouldn't verbalize it and tell you. So I would always be very like, oh, hey, what did you think of the chest exam? And then, if they don't specify a plan, before you move on to the next patient, you can just say, oh, hey, can I just clarify what was the plan for this patient? And then they have to stop and tell you, because sometimes you get swept up and then you haven't kind of finished what the plan is for this patient and they're only talking to the next one. So it's okay to interrupt them and ask them questions. And another thing is when they tell you to order scans or to ask another team for a consult, I would always ask, what's the question for the consult, or what's the main thing we're looking for on the scan? And I think it's better to sound dumb in front of your own team than to pick up the phone and ask for the consult and have the other person say, okay, so why do you want me to see them? And you're just like, my consultant wanted you to, which is a terrible reason. So it's always good, and it's good for your own learning to know what you're looking for, and it makes your job so much easier than you kind of going back and forth and coming back to ask them, because once the ward round finishes, the consultant leaves and you kind of like stuck, and it's hard to ask them questions afterwards. So always ask during the ward round. And then the last thing is to ask questions about career. So you are kind of entering into the workforce, and some of you might already know what general direction you want to go in. If you don't, that is also perfectly fine. I didn't know what I wanted to do at the beginning of internship, but I would say that during this internship year is kind of when you want to figure out a general direction, or at least, a specialty you want to try. Because the reality is you have to apply for jobs in residency, and ideally you would kind of have a bit more of an understanding of the pathway and training of each specialty, and also kind of the selection criteria, and you want to try and do things and they can put on your CV to show that you have interest in a certain area. Next is do be organized and prioritize. I think being an intern is a lot of paperwork, a lot of organization. And honestly, being organized and having a day run smoothly is so important. On the right-hand side, you can see a screenshot of this kind of Officeworks clipboard, which a lot of interns have. If you don't have one, go get one. It's very cheap. It kind of has this component that opens up and the clipboard on top. So in the thing on the inside, I would keep like fluid charts, I would keep consent forms, I would keep medical certificates. So it's actually really good that, when you're on the ward round and your consultant's like, oh yeah, chart them some fluids, you can just whip out a fluid chart instead of running back to the office space, grabbing a fluid chart, and then coming back, or trying to remember this as a to-do later. So it's really handy when you have those, and surgeons love it when they want to consent a patient and you're like, oh, I have the consent form right here. So organize those things, and then on the top, it should be your patient list. So I would say it's advisable to arrive a little bit early in the morning and just to print up the patient list. Each team has their own preferences. Some teams don't mind, you just print it off of the EMR. But especially some surgical teams can be quite particular about their handover sheet. And ask your intern resident, they'll often have an Excel sheet with some smart person would have put like a formula thing where you can input different values and it will print off in like a nice organized table. Like surgical teams, for example, would want to know things like, what were the patient's OBS overnight? What are their drain outputs? How many days post-op are they? So Sometimes you kind of have to do a bit of a pre-round in the morning. If you do come in early though, you should still claim that as overtime, but it just helps to have your day run smoother, and you can have your list to write on about jobs and things like that. In the power chart, if your hospital does have an electronic medical system, you should prepare your notes with shortcuts. So there's two ways I do it. One is to have a pre-completed note. Again, it's probably best if you ask someone who works at your hospital to show you. But it's basically like a pre-completed note, like a ward round note that has the headings. So you don't have to type each time. And also for each term, I would just, for example, if you have the same reg and consultant, I would just have their last names and your last name there. So you don't have to type it for every single patient. And then the other thing is auto text, which is like a shortcut to input a certain text that you've saved. And I would save it with like something I would never type normally. Like it starts with an exclamation mark and then like neuro exam. And then so if I type exclamation mark neuro exam, the whole kind of template for my neuro exam comes out. And then the other thing is have a task management system. Most people I know have a very simple system, which is a pen and paper. You write on the patient list. What I do is whenever I have a task, I draw like a box next to the task. And if I have done it, but then still waiting on some results, I would shade half of it. And then I would shade all of it once it's all done. But just write everything down. Like everyone's mentioned, you're not going to remember it, but write it down on your paper. The somewhat not so great thing is that you have multiple sources of tasks, right? You have your ward round jobs, you have your pager where people will page you about, a lot of random things, and often it's just a number you have to call back. And then you'll have your task list often on an electronic, on your EMR. So kind of you also have to remember that you have tasks from all of those. And sometimes it's very easy to forget to check the EMR. Most of the time though, if someone's put a job up there and you haven't done it in a while, they'll also page you. But it's good to have a set time, after your ward round, you do a bit of a paper round, and just kind of check on the task list, check on your list, and have a list of the jobs you want to do, and you can prioritize them. Initially, I think it's very helpful to have a sit down with your reg after your ward round, just to do a bit of a paper round and prioritize your jobs. Often that can be simultaneous with a coffee break, which is always nice. But I think it's definitely really important to prioritize. I guess obviously I can't teach you how to do everything in these short minutes, but as a general thing is you want to prioritize obviously reviewing unwell patients. So things like clinical reviews and rapid responses you should attend almost immediately, and your reg would go with you. But things like clinical reviews for vitals that are out of the between the flag zone and things like that, unwell patients first. And then it's kind of things like time sensitive clinical jobs, like you need to put in cannula so they can get their antibiotics on time. And then it's consults. You should always try and do that before lunchtime if possible, just so that the consulting team has time to see them in the afternoon. And then it's kind of things like, getting the imaging ordered, getting the making sure the discharges are on time. People will tell you that you need to prioritize discharges, which is fair for the running of the hospital and making sure we're not bed blocked. But I think they'll also all respect the fact that if you have something clinical that is more urgent to do, that you need to do that first. And then kind of after lunch, afternoon things are kind of preparing things for tomorrow. So thinking ahead, like preparing discharge summaries for people will discharge. And at first you might not really get a great sense of who's going to go tomorrow. And it's always great to ask your reg, because they'll have kind of an overview of where patients are at. And then I was told, so don't do the 3 L's, don't be late, don't be lazy, and don't lie. oftentimes it's really scary when you're calling a consult or you're requesting an imaging and people ask you a question and you forgot to ask the patient, and it's so tempting to just say, oh no, I don't think they're a smoker. But if you didn't ask, it's perfectly fine to say, I'm not sure, but I'll go find out. And sometimes, consulting teams can be quite busy and they can be a bit short, but I think everyone at the end of the day knows that interns are learning. No one's ever actually, sometimes people sound a little bit rushed on the phone, but most of the time that they do that, actually they come back and when they see the consult, they're like, oh, I'm sorry, I was really rushed. But I don't think they ever, I know it's like hard to not take it personally, but I think it's just remembering that everyone has their own time pressures. But I think as long as you have an attitude of, how can I help next time to gather the right information, or like, how can we fix this problem? Everyone's usually very helpful. And then however, take a break. It's actually quite hard in the first few weeks to feel like you have time for a water break or even to go pee. But I think the key thing to think about is, even though there are so many people asking you to do jobs, you got to think, is this job going to actually harm anyone if I do this 5 minutes later, right? If it's a person having a cardiac arrest, yes, you do need to prioritize that. But even if a patient is really urgently wanting to go home and hassling people, you can still drink water and go to the toilet and take 5 minutes and come back and do it. It feels really hard. Like, obviously me saying it now, it's like, oh, duh, of course. But when you're in the moment, it's actually really hard to take that space for yourself. One thing I find helpful is to flag to people that that you have all these other jobs to do, but you're just going to quickly grab lunch and then I'll do this. I'll just be 15 minutes and then I'll do this. You can say it to your reg, and ideally, your reg would recognize when it's lunchtime and say, hey, you should take a break. And I've had really great regs who say that to me. But sometimes they're just busy and they forget to tell you to take a break. So you can just be like, oh, hey, by the way, I've done this. Do you reckon it's cool if I go eat lunch? And most of the time, they're very cool with you going to eat lunch. And also try and take a break in terms of outside of work. Try and have a life as much as you can. Keep up with your non-medical friends. It's just nice to not talk about medicine when you're not at work. And if you have hobbies, it's hard to work around the intern schedule, but definitely try and keep them up. And don't do things you're uncomfortable with. So one thing I put is environment in this COVID situation. Make sure you always have the right PPE before you go and see a patient, because your safety actually does matter, because if you can't work, then there's less people looking after patients. And in terms of work hours, sometimes JMSU staffing unit are under pressure and they might ask you to take on shifts. And I just want to tell you that it's very okay to say no. You won't be unemployable if you say, look, I'm sorry, I have plans on this weekend. I don't think I'll be able to take on this extra shift. And in terms of clinical work, you might be asked to do procedures that you're unfamiliar with. And once again, I think it's very fine to say, hey, I haven't done this before. Would you mind walking me through it? Or would you mind showing me this time and I'll do it the next time? And if you're uncomfortable making a clinical decision, or you're worried about, how to assess a patient in this situation, you should always escalate to a registrar, or even check with a resident about what they would do. At the end of the day, you can a reasoning you can use for all of the above is patient safety, because you're not doing the best for patient safety if you're working long hours in an unsafe environment and making decisions you're not equipped to do. So at the end of the day, you are ensuring patient safety by practicing within where you're comfortable with your clinical knowledge. Oh, and the next thing is a practical thing. So do check your pay slip, because you're getting paid now, which is great after so many years of being in uni and not getting paid. So this is an example of a pay slip you're going to get. It's a bit confusing, but you just need to read these boxes. So first is the blue box. So that's the things that you're getting paid for. So you'll have normal hours at a base rate, and normally they pay us. So we work in 80 hours per fortnight, but they pay us 76 hours as a base rate because you get extra ADOs that accrue. And here you have your overtime, and you can check that against your roster about how many hours you've worked. And there's an award where it states after how many hours it turns into double time or 1.5 time rate. And then you can also correlate it with StaffLink. So StaffLink will have a kind of a list of all the hours you've worked and just make sure they're paying you correctly. So that will add up to your gross earnings and you'll get taxed. But if you salary package, you actually get deducted a sum of money before tax. And then, so that then gets salary package. So, and then part of that goes into admin fees and part of that goes to your employer. But then at the end of the day, you get an extra amount of money into your account. Usually it won't be this dramatic. This person just put in all their deductions in one go. And then if you join your like residence social club or whatever it's called at your hospital, there's usually like a post-tax deduction. I would suggest you join. Usually you get free pizza or something every week. And then other financial things as well, make sure you claim your overtime, salary packaging. They will always come and talk to you at O weeks. So get information from Smart Salary or something that does the salary packaging. Get an accountant. There's a lot of places that offer free consulting services for medical interns because they want your business. Take advantage of that and get someone to do your taxes for the first year for free, and you can get an idea of what you need to do. Consider income protection and other insurance. Once again, there's plenty of finance advisors that would give you advice for free. So you should take advantage of that. And then there is, and then invest early if you have extra money. Make sure you're saving for the very expensive house prices in Australia. And don't forget to debrief. So have a nice little wine session with friends. Everyone has, shitty days at work, and our job isn't always, very fulfilling. There are so many little things that are annoying at work, or, there's hard conversations that you need to have with patients, or, there's colleagues that are very stressed and a bit hard to deal with. So always try and talk it out with your friends, medical or non-medical. If there is an incident with a patient where it's a clinical incident, try and debrief with your registrar. Like for example, if a patient had an adverse event or a code. So our hospital, we say code blues for when there's like a cardiac arrest or unresponsive patient. So when there's things like that, debrief with your registrar and talk it through. And remember, it's never just you making mistakes or struggling. Everyone has stories of making big mistakes or struggling with very simple things. Like when I was an intern in my term 3, I had just really rough patch of just not getting cannulas. So I would miss 50% or more of my cannulas. And that's very bad on night shift when half of my jobs were cannulas. And I actually feel really stressed each time I had to put in a cannula. But then kind of when I talk to people, everyone kind of has that same rough patch. And then once you start getting them again, you would just have a good patch and you would just continue to do well in your cannulas. I find that joining some Facebook groups or following some medical meme pages quite entertaining. So some Facebook groups I know. So if you're kind of more into the business or investing, there's like business for doctors, investing for doctors. If you're more into like the branching out into different kind of careers, there's creative careers in medicine. and there's like kind of sorry for the guys, but there's a female only doc to doc group, which is more kind of like a supportive environment to chat about workplace things. And you'll find that a lot of people make anonymous posts about, you know, what they're struggling with at work. And it's very, I think it's helpful to know that there are other people out there in the community that is supportive. And there's a lot of Instagram meme pages like just surge reg things or just med reg things that are quite funny, and make the best out of sometimes not so great situation at work. And that's it. Do you have any questions? Sorry, I went a bit of overtime. Yes, Jeff said, follow EMR Poetry on Instagram. I love that account. It's very funny. It's people write the funniest stuff on EMR sometimes. And Jeff has a great tip in the chat box. I'll let you guys read the chat box. It's a very great tip. You should set that up during orientation week, during your non-clinical orientation week, ideally. So when you hit the floor, you can hit the floor running.
While we wait, can I just mention one thing? Mentals, I can't emphasize more about the mental strength. This work, we see so many bad things happen to other people, and it's only normal, especially those people with the similar situation as ourselves, same age as our parents or same age as our little brother. It hits us harder than others, and it's just normal, and it just needs a healthy mental strength to get through those patches. Yeah,
absolutely. And, you know, it's extra hard as well when we're working long hours and often not seeing our family and friends as much. So I definitely think, you know, it's being aware of it is kind of half the thing, and knowing that it's everyone kind of is in this high stress situation. All right, any questions, guys? If no questions, we'll leave it at that. And I think to all the people here, if there is enough interest, we might do another session soon in the next 2 weeks with perspectives from like a GP, a hospital specialist, and maybe a registrar, kind of to talk about all that kind of side of communication, especially your discharge summaries and how to write discharge summaries that GPs will find helpful. So stay tuned for that session, and we'll talk to you about details soon. All right. And thank you again to our speakers for sharing your wisdom and sharing your knowledge. And I personally loved all the stories that we all share. And yeah. All right. Okay, I'm going to log off now. Thank you, everyone.
Thanks, Lizzie, for organising.
My pleasure. All right. And thank you for all that said. Thank you. All right. See you guys.